Brunnstrom Approach. This was developed in early 1950s. It was a trial and error method. The Brunnstrom approach was particularly designed for hemiplegic subjects, and Brunnstrom used motor control literature and observation on the patients. Basically, a neurodevelopmental approach that describes motor recovery following a stroke as a predictable influence, progressing from flaccidity to spasticity and then finally to near normal voluntary movement, is something known as Brunnstrom approach. In simple words, a fixed sequential recovery pattern that follows a stroke or a recovery that follows a step to step pattern is known as Brunnstrom approach. General principle in Brunnstrom approach is that when there is no movement existing, movement is either facilitated using reflexes or associated reactions or proprioceptive facilitation or extroceptive facilitation to develop the muscle tension in preparation for voluntary control. Treatment progresses developmentally from reflex to voluntary to functional. Brunnstrom also observed that when even only a partial movement is possible by the patient, the reversal of movement from normal pattern is activated. Facilitation is reduced or dropped out as quickly as the patient shows evidence of voluntary control. And emphasis is more placed on the movements that the patient are willing to perform to overcome the link between the parts of synergies. And basically, practice and repetition is the key. Our mind muscle connection weakens post stroke. Therefore, patient is not able to control normal movements. And then thereby we see the movement coming back in a sequential manner. That is the Brunnstrom approach. Before that, we should understand spasticity and synergy. Now, spasticity. It is an abnormal tightness of muscle leading to stiff movements commonly develops post-stroke. Synergy is the coupling of the joint or the muscle in some purposeful movements. For example, movement of shoulder, elbow, wrist happens in a synergy. That is, it happens together in a combination. Now, normal movement has independent joint movements, but in terms of synergy, the control of movement are lost. Basic limb synergies are the mass movement patterns in response to stimulus or voluntary effort or both. So we have a gross flexor movement, that is flexor synergy, gross extensor movement, that is the extensor synergy, and combination of the strongest component of the synergies, that is called as mixed synergies. These appear during the early spastic period of recovery. As we said, that patient develops spasticity first in the stronger components of flexor and extensor synergy. Certain rules are made in the Brunnstrom approach to follow the movement recovering and not force into new movements. So thereby we should accept the movement present, that is synergy early on. Then we need to facilitate the available movement and do not suppress them. Thereafter normalize as the recovery progresses. Thereafter there will be gradual gain in the independent and active control. Brunnstrom approach has given us a very beautiful stage-wise representation of each movements they have observed, what movements the person can perform, and what amount of tone or spasticity is there in each stages, so that we can understand the patient's recovery, where the patient stands in the recovery phase. Starting off with the first stage, that is flaccidity, wherein the muscle tone is absent or zero. There is no voluntary movement. There is no reflexes, so deep tendon reflexes are absent. Second stage is the beginning of spasticity, that is where weak movements are present and there is spasticity beginning. So we see spasticity develops first in stronger components of the flexor and extensor synergy. For example, biceps in the paralytic upper limb, quadriceps in the paralytic lower limb, and we get to feel resistance to passive movements. Secondly, there is a basic limb synergy that starts to initiate as associated reactions. Basically, when patient puts extra efforts than normal side, then there is a reflexive stimulation of the basic limb synergy in the hemiplegic side. Also, we get to see some patient can exhibit some voluntary movement in the paralytic side. The stage 3 is maximum spasticity. We get to see that patient can now initiate and perform basic limb synergy, but it's not necessary that they can complete full range of motion. So semi-voluntary control phase is there, that is only on initiation of the movement, but not on the outcome. Therefore, outcome will always be either flexor or extensor synergy. Definitely tone is maximum and patient cannot isolate the joint movements. The stage 4 is decreasing spasticity. Here the tone is getting down and it keeps on declining. So now the patient masters certain movements outside basic limb synergy. With extra efforts, they can produce movements outside this synergy, and gradually as the spasticity further declines, the movements get easier to perform. So overall improvement in voluntary control is seen. Stage 5, independence from synergy. That is, this spasticity even further declines and better control and coordination is now being achieved. Therefore, now the patient can master variety of movement combinations and no longer is confined to only basic limb synergy and makes key movements very easy. That is, more complex and selective movements are now possible. Stage 6 is near normal movement. That is, spasticity completely disappears and the individual joint movement is now possible. With near normal coordination and voluntary movement, therefore patient performs isolated voluntary joint movement with variety of movement combinations. Stage 7 is normal voluntary movement. It is said that it is a rare scenario that patient will completely recover and reach the stage 7. So here restoration of all normal functions are seen, complete independence in all activities of daily living. The movements are in a normal, purposeful, coordinated manner. The Brunnstrom approach also says that the person or the patient is not supposed to be fitting into a specific stage in any recovery phase, and therefore we should always keep a check on their movements and everyday pattern and not focus solely on the stage-wise recovery. And it is not necessary that each patient will go through each of the phases or each of the stages. Therefore, we need to understand and assess similarly. We have certain tests given by Brunnstrom approach that helps us understand movements to determine if the patient has come into the stage 4 or the stage 5 respectively. Now we ask them to take the hemiparalytic upper limb and place it behind the body, basically do a shoulder internal rotation. Secondly, we ask to perform supination and pronation with elbow 90 degree flexed. Third, to horizontally elevate the hemiplegic upper limb, the shoulder flexion basically while keeping elbow extended. If the patient does one or more of these key movements, we can say that the patient is in stage 4. Although it is not necessary that upper limb and lower limb are together into stage 4. So the lower limb has to be tested as the knee has to be flexed beyond 90 degree in sitting by sliding the foot. Secondly, perform dorsiflexion in sitting without lifting the foot off of the ground. If the person can perform horizontal elevation beyond 90 degree or abduct the shoulders 90 degree with elbow extended and supinate or pronate in the abducted shoulder 90 degree with elbow extended position, and isolated knee flexion during standing, keeping the hip extended or keeping the hip neutral. Secondly, isolated ankle dorsiflexion in the step standing position. Then we can say that the person has arrived at stage 5.